This diabetic retinopathy happens because of a very high glucose load. Okay, and that can also be happen because of a prolonged increase in the blood glucose level. Okay, uncontrolled blood sugar. Okay, so a prolonged history of having a high blood glucose or an uncontrolled type of glucose that can lead to the diabetic retinopathy. Okay, it happens because of the chronic hypoglycemia. Okay, this diabetic retinopathy is of two types. Okay, one is the non-proliferative and second is the proliferative type. In case of non-proliferative diabetic retinopathy, you're having a damage of the capillaries, as you can see. Okay, these are our capillaries, and you're going to have a damage of these capillaries. And does anyone can tell me why this damage is occurring to the capillaries in diabetes?
Vasculopathy because of diabetes, glycation.
Yeah, because of the glycation, right?
Glycation.
You have the deposits of all these proteins which are glycosylated, right? And that will make the blood, these blood vessels very much leaky, right? Weak and leaky. So as a result, you will have a damage of the capillaries. You have a leakage of the blood along with the blood, and you also have some lipids, right? So lipid will be leak and they will all seep into the retina. So what you will see are the hemorrhages and the macular edema because of that. Now, second type is a proliferative type in which you're having a chronic hypoxia, and that can lead to a new vessel formation, release of the VEGF, new vascularization, hemorrhage. In both the conditions, the macular, the ARMD, and in case of diabetic retinopathy, in both the conditions, you're going to have the hemorrhages, exudates, right? All this blood vessel proliferation. So how will we differentiate between the diabetic retinopathy case and a case of ARMD? Anyone? In both the conditions, you're going to have all this hypoxia, VEGF release, hemorrhages, exudates. Everything is similar in both this retinopathy and the ARMD. How will you differentiate between the two on the fundoscopic findings?
ARMD will include the macula specifically.
Exactly. In ARMD, you have only the macular involvement, right? All the vision changes, everything, every symptom you will see, it's only affecting the central vision field, the distortion, the change in color, the blurring of vision, the fundoscopic findings. Okay, it will all be, maximum at the center or at the macula, right? But in case of diabetic retinopathy, it is happening diffusely throughout the retina. Okay, so all these changes will be seen throughout the retina, right? So let's discuss what changes you will get again. Okay, so first is a non-proliferative diabetic retinopathy in which you're having a damage of the capillary walls. Aneurysms will be seen, and you will have a micro hemorrhages because all the deposition of these glycosylated products, you will have a damage of the capillary walls, and that will make them very much weak. And as a result, you will have the aneurysms, you will have the rupture of these vessels, right? Leakage of the lipids and the proteins from the blood vessels will happen, and that will deposit on the retina and will seen as the hard exudates. Okay, you will have the ischemia of the retina, and because of that, you will have a this cotton wool-like spot. Because the cell dies, you will have an inflammation, and that will present as the cotton wool-like spot. So both the hard exudates as well as the soft exudates, just like my ARMD, you will see in the diabetic retinopathy, non-proliferative type. Okay, so on the fundoscopy, we will have a multiple hemorrhages, aneurysms, cotton wool-like spots, and hard exudates. And you call them a dot hemorrhages. As you can see, these are the hemorrhages you will see. Okay, this is central macula. You have these aneurysms, if you guys can appreciate. These are the aneurysms. You will be having a hard exudates. You will be having a soft exudates along with the hemorrhages at multiple areas, right? So these are the findings you will see on the diabetic retinopathy, which is non-proliferative type. Then you have the proliferative diabetic retinopathy, in which the patient will present you with a decrease in the vision, and the presence of floaters will be there. They will told you that they have, what they're seeing some kind of a floating structures in their eyes, in their vision. So these are the floaters, right? And these are the two highly characteristic features that will tell you that the patient is having a proliferative diabetic retinopathy. You will have a hypoxia, and as a result, you will have a VEGF that can cause a neovascularization. More hemorrhage will be seen. Retinal detachment can be seen on this thing. So in the fundoscopic finding, you will have a findings of the non-proliferative retinopathy along with the neovascularization. So having a neovascularization will help you determining that the patient is having a proliferative retinopathy and not a non-proliferative type. This is a hallmark feature, the neovascularization. As you can see, all this neovascularization is happening, and you can see all these hemorrhages also because of the neovascularization, right? And that is the macula. You are having this optic disc here. Okay, so that was about the diabetic retinopathy, non-proliferative and the proliferative type. Okay, so yeah, any doubt?
No, thank you.
Let's go back to the first step again. So that was about my diabetic retinopathy. Okay, symptoms will be in case of proliferative, the blurring of the vision and the presence of fluid. These two are the important findings. On the symptoms and on the fundoscopic, that means on the examination, you will see the all these neovascularization in case of proliferative one. Then you have the hypertensive retinopathy, and that happens because of a malignant hypertension, which is uncontrolled type. Like I told you, you have two type of hypertensions, a very high severe kind of hypertensions. These are the malignant type, or you can say hypertensive emergency, and one is a hypertensive urgency, right?
Yeah.
And in case of urgency, you just have the hypertension without any symptom, without any end organ damage. In case of hypertensive emergency, you're having a damage to your organs like eyes, brain, heart, liver, kidney, any organ. And as a result, you will have, along with the hypertension, you have at least one symptom. So that is, one of the symptoms is the diabetic, one of the symptoms is the hypertensive retinopathy. Because of this high or uncontrolled BP, okay, you will have a necrosis in the vessels of your retina. Okay, you will have a flame shift retinal hemorrhages. Okay, you will have a AV nicking because, because of this hypertensive, uh, because of the hypertension, you will have a proliferation of these vessels. You will have a vessel thickening arteriosclerosis, and as a result, it will make the vessels hard. So at the point where the arteries crosses the vein, they will compresses the vein at that point, and that will lead to the atriovenous nicking. Okay, you will have the microhemorrhages or and these microaneurysms, just like my diabetic retinopathy. You will have a macular star, that is the X2-8s, as you can see. These are the X2-8s you will see, right? Just like my diabetic retinopathy or ARMD, you will see that conditions. Cotton wool-like spots, and that's happening because of the retinal ischemia. Because of this arteriosclerosis, you're having a narrowing of the vessels, and as a result, the blood supply will be decreased. You will also have the papilledema, and when you have the papilledema, that means you're having a high intracranial pressure, and that means you need a immediate lowering of the BP if you have the papilledema, because in that case your brain is dying, right? You have an increased risk of stroke and the CAD uh, uh, and this kidney disease. Whenever you have the this hypertensive retinopathy, that means you either can be having a kidney disease, right? You guys know that it happens because of any blockage in the renal vessels, right? Patient will have an increased risk of developing any cardiovascular complications, like a stroke can also happen, right? So that's about my hypertensive retinopathy. Any doubt?
No, thank you.
No, thank you.
So look for the flame-shaped hemorrhages, AV nicking, aneurysms, right? And yeah, and this cotton wool-like spots. These four findings you will see on the this hypertensive retinopathy. Then you have the retinal vein occlusion, as the name suggests. In that case, you're having an occlusion of the vein, and as a result, the drainage of the vein from my retina will be decreased, completely inhibited, right? As a result, you're going to have a engorgement of all these vessels, all these veins. They will become very engorged, right? And that exactly what you will see on the fundoscopy. You will have the venous engorgement, and that will appear as a blood and thunder appearance. Okay, that compression of the vein can be happen because of a nearby arterial atherosclerosis that will make your arteries thick and kind of big. It can happen because of any aneurysm in the artery, right? And that can lead to the hemorrhage and the venous engorgement. That two things will be seen because your veins are kind of very much leaky, and when the pressure increases in the vein, you will have a leakage of the blood, and that can lead to the retinal hemorrhages. So these two things will be seen on the fundoscopy. Okay, any doubt?
No, thank you.
No, thank you.
Then you have the retinal detachment, and it is basically the separations of the neurosensory layer of the retina, because you have multiple layers of the retina, right? You have a pigmented epithelium, layers of rod and cone, then the ganglionic cell, bipolar cell, right? And whenever the neurosensory layer of the retina separates from the pigmented epithelium, you call it a retinal detachment. Okay. And basically, the most common cause is any trauma, or it can happen because of the proliferative retinopathy, like we have discussed before, right? And it, it appears the symptoms will be like, a monolocular loss of vision, like a curtain drawn. Okay, it would be a patient who is having a sudden loss of vision, complete loss of vision will be there in the affected eye. Okay, and on the examination, you can see this kind of a detachment of the retina. If you guys can appreciate, this is a detachment of the retina you will see on the fundoscopic findings. Okay, it can happen because of a diabetic retinal distraction. It can be happen because of an inflammatory effusion. It can be happen because of any trauma, and that is the most common cause, of course. On the fundoscopy, we are thinking of the retinal tissue. As you can see, this is a retinal tissue. You will see just like a line on my fundoscopy. Okay, and yeah, that's all about the retinal detachment. So a patient with a history of either the trauma or the diabetic retinopathy, or a patient with an inflammatory disorders in the eye, and now he's having a sudden monocular loss of vision, think about the retinal detachment. Okay, any doubt?
Could you please repeat the last sentence?
The monocular loss of vision,
No, I mean, how does the patient present usually?
just a monocular, sudden monocular loss of vision will be there in the patient.
Okay, okay. Thank you.
Like someone is drawing the curtain over them, right?
Okay, yeah. Thank you.
Could you show on the picture the retinal detachment, how look like?
This is how it look like. You have this line kind of things on the, see, if I annotate, if you have this fundoscopy, this is a retina, it will appear just like that. You see some kind of a lines on the on the fundoscopy. Okay, and whenever you see this kind of a line, okay, in your fundoscopy, that means it is a retina which is this the detachment of the retina is occurring. Okay,
Okay, thank you.
these kind of a lines will see on the fundoscopy.
Yeah, okay, thank you.
And they must have a history. That is the important thing. They might be having a history of trauma or a diabetes or an inflammatory disorder of the eye, so that can affect, right? So any doubt on this page so far?
No, thank you.
Okay, now comes a central retinal artery occlusion, and as the name suggests, you're having an occlusion of the artery supplying the retina. Okay, now why this occlusion can happen? It can happen because of any atherosclerosis of the eye. It can happen because of a thromboembolism. It can happen because of a giant cell arteritis. If you guys remember the giant cell arteritis, where you're having a monocular sudden loss of vision, right?
Yeah.
Yes.
So these three things can happen and can lead to the central retinal artery occlusion. And whenever the artery occluded, you will have a loss of blood supply to your retina, and as a result, what you will see is a acute painless monocular loss of vision. It would be a sudden, okay, it would be painless, and patient will have a loss of vision completely. Okay, now see, because all this reddish thing you're seeing on the fundoscopy, the reddish right now you're seeing on the fundoscopy, it's all because of the red blood, right? When this blood is lost, what you will see is a pale fundoscopy. You will see the paleness of this retina, right? But one part I told you has a dual blood supply, and that was the macula, right?
Yes.
Yeah.
In the center of macula, you have the fovea. So on the fundoscopy, what you will see is the pale fundoscopy, completely pale, right? But it has a central red dot, and that is the macula. Okay, so it will appear as a cherry red spot at the macula or at the fovea. Okay, so a patient who is having a sudden painless loss of vision, on the fundoscopy you're seeing a cherry red spot on the macula, and rest all the retina is pale. Think about the central retinal artery occlusion. Now, If you guys tell me you have two more conditions in which you can have this choroid spot.
Tay-Sachs and
Tay-Sachs
Niemann-Pick.
and Niemann.
So how can you differentiate between the Tay-Sachs Niemann-Pick and the central retinal artery occlusion?
The age of the patient?
Exactly. The age of the patient is important. If you encounter a child, a neonate, a child, and they're having this the red spot, think about the Niemann-Pick disease or the Tay-Sachs disease. If you encounter an old age patient or an adult, and now they are having this red spot, think about the central retinal artery occlusion. So it's all about the age, right? Especially if you're having a patient who is more than 50 or 60 years old, and they are having this CRA, think about the giant cell arteritis, because that is a very common cause, right? And they especially have this proximal pain in the shoulders, in the pelvic girdle, right? They have this kind of a pain in the head, in the jaw. They have a difficulty chewing because of this pain, right?
Yeah.
So if you have these kind of symptoms along with this loss of vision, think about the giant cell arteritis, and patients especially have the high ESR. Okay, so a pale retina because of the ischemia and a cherry red macula that you will see on the central retinal artery occlusion. Any doubt?
No, thank you.
So if the vein occlusion occur, you will have a engorgement and the edema and the hemorrhage. If the artery is occluded, you will have the paleness and the cherry red spot. Then comes the retinitis pigmentosa. And does anyone remember a disorder in which we have this retinitis pigmentosa?
Refsum and A beta lipoproteinemia.
Yeah, refsum and the A beta lipoproteinemia. Very good. Okay. And so what's actually happening, as the name suggests, you're having a pigment deposits on the retina, and these pigments are nothing but due to a damage of the retina itself. Because in the retina you have this pigmented epithelium, and when the pigmented epithelium damaged, you will have a leakage of all these pigments, right? And all these pigments will start depositing on the retina, and they will appear as these kind of pigments. So it is the retinitis pigmentosa. It is a inherited progressive retinal degeneration. You will have a degeneration, and as a result, all these pigments will leak out from the cells. Okay, you will have a peripheral loss of vision. Bone and spicular shaped deposits will be seen, as you can see, right? You will have an area of dark discoloration. Okay, and that because of a degeneration of the retinal pigmented epithelium that releases all the pigments. You will have a pale optic disc because of the optic disc atrophy. Okay, and yeah, that's all the findings you will see. So please remember, it is a genetic dystrophy or a genetic condition. It is hereditary, right? You will have a damage of the pigmented epithelium and a pale optic disc. These 3-4 findings you must remember for the retinitis pigmentosa. Any doubt?
I have one question from CRAO.
Yes.
Could you please again explain how to differentiate Niemann-Pick and Tay-Sachs from CRAO?
Age of the patient. If you encounter a child, that means they're having a Tay-Sachs or the Niemann-Pick, because the patient won't survive in the adult, right?
Yeah, yeah.
So you never can encounter a Tay-Sachs disease or Niemann-Pick disease having an age of like 50 or 60 years.
Right. Okay. Thank you.
Age of the patient is important. Okay, now you have the papilledema. You have discussed that already. In case whenever you have a high intraocular pressure, whenever you have high intracranial pressure, that pressure will transmit through the optic nerve because it contains all the meninges, and as a result, you will have a edema of the optic disc. You have a damage of the optic disc and lead to the papilledema. Okay, it will be the optic disc swelling, and it appears as the blurring of the margins of the optic disc. Okay, normally you have this kind of very demarcated optic disc, right? In case of papilledema, you're gonna have all this blurring of the margins like that. Okay, these kind of a blurring margins you will see on the optic disc. And you think about the papilledema. Patient will have a history of headache. They will have, they will have the precipitation of these headaches whenever they perform any exercise that can increase the intracranial pressure, like lifting a weight or the Valsalva or sleeping, okay, or upside down position, right? So the patient will have a history of headache. They will have a history of blurring of the vision. On the fundoscopy, you will see the blurring of the optic disc margin. You will have a high CSF pressure, right? And you will think about the papilledema after that. Any doubt?
No, thank you.
Then you have the leukocoria, that means a loss of red reflex. We have discussed why the red reflex occur, right? But if you have any opacity in your lens, that will prevent this red reflex, right? And the most common, or you can say a most important cause in children is the retinoblastoma. Okay, it can happen because of a congenital cataract, like in case of my rubella syndrome. You can have this in case of toxocariasis, right? So remember three causes: toxocariasis, congenital rubella syndrome, and the retinoblastoma. All of them can cause a leukocoria, loss of red reflex. Okay. In case of retinoblastoma, you have this cataracts along with the what cancer you will get?
Femoral bone cancer, osteosarcoma.
Osteosarcoma. Good. Osteosarcoma you will get along with the retinoblastoma. Okay. These two things for the retinoblastoma gene disorder. Okay. So you will have a loss of this red reflex along with the bone pain. Think about the retinoblastoma. Any doubt?
No, thank you.
It can happen because of the retinoblastoma. It can happen because of any opacity in the lens, as you can see. Okay. And then you need to know about the concept of the immune privilege. There are certain tissues in your body. They have developed a kind of resistance to all these immune cells. Okay, they have this kind of a barriers which will prevent the immune cells from entering in those tissues. Some of the examples are the eyes, testis. You have the brain that has the blood-brain barrier, right? So all these tissues will prevent the immune cells from entering into them, and as a result, all the antigens these tissue have, okay, your immune cells are not sensitized with these antigens, right? They do not recognize these antigens, although they are self, okay, but your immune cells are still not sensitized with these antigens, right? Now, what happens sometimes whenever you say, you have this negative selection and the positive selection, right, in the thymus, right?
Yes.
Whenever either of the selection fails, and especially negative selection, you will have some autoimmune cells in the blood vessels, right? Because the function of the negative selection is to eliminate the autoimmune cells, right?
Yes.
Yeah.
If this negative selection fails somehow, that and that happen regularly, you will have the release of autoimmune cells in the blood, right? Now, in a scenario where the barrier that is preventing all these tissues from the immune cells got damaged, okay, then you have normal cells, the normal immune cells. They won't attack these tissues because they are normal and they know that these are our self tissue. Okay, but those autoimmune cells that were into my bloodstream, they can reach to these tissues and they will become sensitized with their antigen, and they will mount the inflammatory response against these antigens, right?
Yeah.
And that exactly happens whenever you got an eye injury. Okay, let us suppose you got any kind of a trauma in the eye that damage your eye completely. Okay, in that case you have two options: either to remove the eye. Okay, if you think that your eye is it cannot be repaired, it cannot be you know what do you call it, wound reparation, right? In case if your eye is cannot be repaired, then the surgeon must have to remove the eye. Okay, in a scenario where they think that eye can be repaired, can be regenerated again, in that case they will have to give you the all these corticosteroids in order to prevent the inflammation, because whenever you got any kind of a damage in the eye, the barrier which is preventing the immune cells from entering the eye, it is not damaged. So now the antigens which were not previously immunized, now all these cells will become sensitized to these antigens, and if they become the autoimmune cells, then they start attacking the eye, right? A classical case will be a patient who is having a trauma in one eye, okay, and you just repair the eye, the patient has begun restoring the vision, okay, they have the improvement in the vision, but suddenly after like 1 month or 1 week later, they're presented to your emergency department with the pain in both the eyes and a vision loss in both the eyes, right? And that happening because of the loss of immune privilege, because with that trauma you have damaged that barrier, and now these autoimmune cells are attacking both these eyes, right? Not just single eye, but both the eyes. So although trauma is happen only to one eye, but now the inflammation is happening in both the eyes, right? And that is the immune privilege. Okay. And the certain immune privilege, the mechanisms include the decrease in the MHC1A, the lack of lymphatics in these tissues, Physical barriers are also present, right? Now, the self antigens are located at these sites, okay, and they have the immune privilege. That means they cannot be recognized, okay. But whenever the barrier damage, they can be recognized by the self-reacting T cells, okay, that escape the negative selection. Now, these self-reactive T cells, whenever the antigens get released into the lymphatics because of a damage, right, they will become sensitized, okay, and they will mount a response that can affect both the eyes, injured as well as the contralateral or the normal eye. So in a scenario, okay, when the eye is severely injured, okay, and the patient has no prognosis for the recovering, right? So you will have to surgically remove the eye to prevent the blindness in the uninjured eye. However, if the patient has a chances of restoring the vision, okay, in that case, you have to give them the corticosteroids to prevent the blinding, to prevent the inflammation against the eye. Okay.
Yes.
So any doubt on the immune privilege?
No, thank you.
Actually, can you explain point? How is it if there's no connection between the two eyes? How is it
Yes.
going from one cell to the other eye?
You have lymphatics, right? Whenever a damage happen, you have the leakage of antigens. And once your cells know that these kind of antigens are present in your eyes, they will start mounting the inflammatory response. And when the inflammation occur, like in case, see the meningitis, whenever they have the inflammation in the brain, in the meninges, the blood-brain barrier got damaged, right? And once the blood-brain barrier got damaged, all these cells can be entered in the brain, right? No?
Okay. Okay.
Yes. So
Yeah,
similarly, in
and
case of eyes, once the cell knows that these antigens are present in the eye, they will start mounting that inflammatory response. And because of that, all the barriers got damaged in both the eyes.
okay.
And once the barrier got damaged, these cells can enter the eye. They will again mount the inflammatory response and they will damage both the eyes after that.
Okay. So on the second point, when you say recognized by self-reacting T cells that escape negative selection, so this can happen even in people with normal immune systems? Some of their self-reacting T cells can get away?
Yeah, sometimes that can happen with anyone, with you, with me.
Okay.
That
Okay.
can be happen. Yes. That's why you have all these diseases, right? All these autoimmune diseases, rheumatoid arthritis, and all other diseases, right? You're having, it's only because all these self-reactive T cells, they're escaping the negative selection somehow, sometimes, right? And whenever they escape, they will mount the inflammatory response to any of their self antigens, right? It happens generally.
Thank you.
Any more doubt on the immune privilege?
No, sir.
No, thank you.
Okay, so we are done with most of the ophthalmology, and now come the neuro-ophthalmology. Okay. First, you need to know about the meiosis, how this constriction of your pupil occur. Okay. Now, so the first neuron, they will be originated with the Edinger-Westphal nucleus. And does anyone remember where this nucleus present? On the periphery or in the center?
Center.
Now, on the periphery of my third nucleus, okay, third cranial nucleus. I mean, the whole nucleus is in the center of my midbrain, but in that nucleus, you have two parts. One is the peripheral part and one is the central part. In the central part, you're having the motor nucleus. In the periphery, you're having a Edinger-Westphal nucleus, right? So when the nerve originated, when the nerve is going to your eyes, on the periphery of the nerve, you're having the Edinger-Westphal nucleus. Okay, all these fibers which are from the Edinger-Westphal nucleus. In the center of my this third nerve, you're having all the fibers from this motor nucleus. Okay.
Yes.
Okay.
And that's why in case of any aneurysm, first you have a damage of the Edinger-Westphal nucleus and then the damage to the motor nucleus happens. That is the reason, okay? So the first neuron, it will originate from the Edinger-Westphal nucleus and it will travel to my ciliary ganglion via the third cranial nerve, right? From the ganglion, you have the short ciliary nerves and that will cause the sphincter pupillae muscles to contract, and as a result, you will have a constriction, you will have a meiosis. So remember, short ciliary nerves will shorten the pupil diameter. That's how you can remember, right? So as you can see, you're having this Edinger-Westphal nucleus, right? From the Edinger-Westphal nucleus, you're having the origination of this third cranial nerve, right? It will travel to my ciliary ganglion, and in the ciliary ganglion, the short ciliary nerves will cause the constriction at the pupil. Okay, and that's how you will have a light reflex. Okay, now how this whole light reflex works? So you have two limbs. One is the afferent and one is the efferent, just like any other reflex pathway. So for the afferent limb, you're having the second cranial nerve, the optic nerve. Okay, you have the optic nerve, as you can see. The optic nerve will take all the information from the retina. Okay, now it will go and finally it will reaches to the pretectal nuclei. Okay, it will send the signal to the pretectal nuclei, as you can see. Okay, so once let's see, once you have the activation of all this second cranial nerve, whenever you shine a light or whenever you see something, okay, your optic nerve has multiple pathways to take that information. Okay, let's discuss all these pathways. So after the optic chiasm, okay, when the optic light begins, okay, the fibers can be projected to the lateral geniculate body. Okay, and from the lateral geniculate body, the fibers will be projected to my primary vision cortex, that is within my occipital lobe, right, for the visual field. Second, you have after this optic chiasm, you have the transmission of the fibers to the pretectal area, and from there you can have a pupillary light reflex. Okay, after that optic chiasm, you will have a transmission of the fibers to the superior colliculus, and you guys know that superior colliculus is responsible for the vertical gaze, right? And from there also, and from ear also, in the cranial nerve 8, you have a transmission of all these fibers to the pons, okay, and then to the midbrain, and finally you will have a horizontal gaze. Okay, so from cortex, from ear, okay, you will have a transmission of fibers to the pons. From pons, the fibers will transmit the information to the midbrain, and you can have a horizontal gaze. From the optic nerve, you have mainly these three pathways: the lateral geniculate body, the pretectal area, and the superior colliculus. The lateral geniculate body for the visual field, the pretectal area for the pupillary light reflex, and the superior colliculus for the vertical gaze. Any doubt on these pathways?
No, thank you.
Okay, so once you shine the light, the optic nerve will be stimulated and it will transmit the information to my pretectal area, which is located in the midbrain. Okay, now from this pretectal area, you will have activation of bilateral. Okay, the one-sided pretectal area can stimulate the bilateral Edinger-Westphal nucleus, and that is the important thing. Okay, and that's how you will have both the direct. Okay, let's say you shine the light in the left eye. Okay, the optic nerve from the left eye will be activated. It will transmit the information to the left pretectal area, right? This left pretectal area will stimulate both the right as well as the left Edinger-Westphal nucleus, and as a result, you will have a direct the pupillary constriction, and you will have a consensual pupillary constriction, right? Okay, that's how you will get the light reflex. So if you shine the light in one eye, you will have a constriction of both the eyes, and that's because of the pretectal nuclei. Any doubt?
No, thank you.
No, thank you.
Second, you have the mydriasis. Okay, and the information for the mydriasis originates from the hypothalamus. The first neuron will travel from the hypothalamus to the spinal cord up to the level of T2. Remember the Horner syndrome?
Yeah.
And that is a descending hypothalamic pathway, right?
Yes.
So all these fibers will originate from the hypothalamus. Now they will travel up to the level of T2, okay, and they will exit your spinal cord. And after exiting the spinal cord at the T1, they will travel to the superior cervical ganglion, okay, and they have to synapse in the spinal cord, right? After synapsing, the neurons will exit, okay, the neurons will exit my spinal cord and they will enter the superior cervical ganglion, okay, and they will travel along the sympathetic chain. Okay, and this chain passes near the lung apex, and that's why whenever you have a Pancoast tumor, that means the apex of the lung, whenever they have a tumor, they can compress the sympathetic chain and they can cause the Horner syndrome, right?
Yes.
Yeah.
because this chain passes very close to the lung apex. Okay. Now, after this chain, you again have a synapse. Okay. And then you have the third neuron, okay, which travels along the internal carotid artery. Okay. It travels along with the internal carotid artery. It will enters the cavernous sinus. Okay. We will discuss what this sinus is, what nerves it will carry, right? But just know in the brain, you have the cavernous sinus. Okay. All these nerves will travel into the cavernous sinus, and then it will reaches as the long ciliary nerve. Okay. And the long ciliary nerve will causes the dilation of the pupillary muscles. It will cause the constriction of the dilated pupillae, and as I said, it will have a dilation of the pupil, right? So the long ciliary nerves make the diameter of the pupil long, right? So along with this fibers, you also have the fibers for the sweat gland, right? And that's why in the Horner syndrome, you have the meiosis, anhydrosis, and
Ptosis.
ptosis. Okay, because or this third nerve passes through here, right? All the nerve fibers for the sweat glands, they passes through here, right? And the nerve for the dilation of my pupil passes through here, right? So whenever you have a compression of any of this nerve along any in the first neuron, in the second neuron, in the third neuron, you can have a Horner syndrome. In the first neuron, you can have a damage along up to the level of your spinal cord, up to the level of T1, you will have a damage of the first neuron. If you damages your sympathetic chain, you will have a damage in the second neuron. If you got any damage in the cavernous sinus, that means you're damaging your third neuron. With all the strokes that you guys studied previously, the little medullary syndrome, the little pontine syndrome, you're damaging the first neuron, right? And if you guys remember the this Brown-Séquard syndrome, right?
Yeah.
In that case, you're damaging your first or second order neuron?
First.
First order neuron. Okay. In case of any Pancoast tumor or any mediastinal type of mass, okay, you're damaging your sympathetic chain. That means the second neurons. With a cavernous sinus thrombosis, if that happens, you're damaging your third neuron. Any doubt on the mydriasis?
I have one question.
Yes.
Since the second order neuron is near the subclavian vessels, is there any clinical significance of that?
If you got if you got a dissection of a carotid arteries, you can have a loss of blood supply. You will have got this hemorrhage, along with the Horner syndrome, and it will be very painful condition for the patient also.
So that can include the subclavian vessels.
Subclavian vessels, I think that generally won't happen. See, in case you're having any mediastinal mass or any Pancoast tumor, because these condition structures are very much close to each other, you can have a Horner syndrome along with the superior vena cava syndrome or a subclavian vein syndrome.
Yeah.
That would be a significant thing. Don't worry, we'll study that later in the respiratory section.
Yeah.
Whenever you have any mediastinal mass, you can have a compression of this ganglia, this chain, sympathetic chain, along with the compression of the veins also, either the subclavian vein or the superior vena cava, right? And that's why the syndromes are subclavian vein syndrome or the superior vena cava syndrome.
Okay. Yeah. Thank you.
Okay, now you have the Marcus gun pupil, and that happened in what condition, if anyone remember?
Optic neuritis.
Yeah, the multiple sclerosis. Multiple sclerosis, right? It is also known as, look for the name, relative afferent pupillary defect. That means you're having a defect in the afferent limb. And what nerve is carrying the afferent limb?
Second
nerve. That means you're having a defect in the second nerve, and that is the optic nerve, which makes sense because in case of a multiple sclerosis, I'm having a upper motor neuron damage, right?
Yes.
Or I can say all these nerves which are lined by my oligodendrocytes, and that is my second nerve. So in case of Marcus gun pupil, you're having a relative afferent pupillary defect. Okay, so when you shine the light in the normal eye, let us suppose you're having a damage in the left-sided eye, okay, this optic nerve, and your right-sided eye is absolutely normal. Okay, so when you shine the light in the right eye, you're having a normal response, the direct response as well as the consensual response, because a third nerve is normal. So it will cause a contraction. But once you shine the light in the abnormal eye, instead of constriction, you will have a dilation of both the eyes. Because this optic nerve cannot carry any information from the second from this left eye. And as a result, if you shine the light, it won't take any senses, you won't have any constriction. So even if you shine the light, you will have a dilation of both these eyes. And that is the Marcus gun pupil. Okay, you can check this defect by shining the light into the normal eye. Okay, and as soon as you get this constriction, you will shine the light in the abnormal eye. And instead of constriction, you will see the dilation in both the eyes. And that's how you know that the patient is having a Marcus gun pupil. Is that okay?
Yes.
So that was about the Marcus gun pupil. Now, why you guys are having a dilation? Why not just a normal?
Because when we are shining it on the normal eye, it has already caused a
Yeah.
constriction.
Yeah, it has already got the constriction, and that's why we will have a dilation. Okay, that was the important thing. So on the exam, they will give you a table type of thing, and they will give you some examinations, right? That you shine the light in one eye, you're having a constriction. You shine the light in second eye, you're having a dilation. You shine the light in both eyes, you're not having any constriction, or something like that. Okay, and they've described you a kind of a scenario in which the patient is having either the relative afferent pupillary defect or the patient is having a relative efferent pupillary defect, and they will ask you what option is true. Okay, for the examination, so you have to choose this. You have to choose the option from that table, right? So similar to my relative afferent pupillary defect, you're also having a relative efferent pupillary defect in which you're having a damage in the third cranial nerve, the motor nuclei, or sorry, you can say the Edinger-Westphal nuclei of the third cranial nerve. And as a result, if you shine the light in the normal eye, you can have a direct response, but not the consensual response. If you shine the light in the abnormal eye, you will have the consensual response, but not the direct response. Are you getting my point?
Yes.
And that is known as the relative efferent pupillary defect. That means because the third nerve of this left eye is not damaged, so you cannot have either the direct response in this left eye and nor the this consensual response, right? So even if you shine the light, you will have a consensual response in the normal eye. If you shine the light in the normal eye, you will have a direct response in the normal eye, but not in the abnormal one. Okay. So you have to differentiate between the REPD and the RAPD. They will give you this table. They will describe you this examination of the patient, and they will ask you what is the correct option, right? You have to choose that. So any doubt on this page?
No, thank you.
Okay, now you have the Horner syndrome. We have discussed the pathway already. This pathway is originated in the hypothalamus. It will travel all the way down to your T1 level of the spinal cord. From T1, it will synapse, and the second order neuron will exit. Okay, it will travel along the sympathetic chain, right? After sympathetic chain, it will again synapse. After synapsing, it will travel along the external carotid artery. Okay, and from there, it will give some of the long ciliary branches, right? And that will cause the dilation of one pupil, right? So whenever along with that, you also have the fibers for the sweating. You also have the fibers for the for the opening of your eyes, right? So whenever you have any damage of any fiber of this pathway, whenever you have a damage of the sympathetic fibers along anywhere on this pathway, you can have a Horner syndrome. Okay, you will have a ptosis, that is a drooping of the eyelids. You will have an anhidrosis, that means absence of the sweating. And because the sweating is not there, the vessels will dilate on the skin in order to lose the heat, and you will get the flushing. So instead of loss of sweating, step 1 will give you a patient with the flushing, right? And you guys have to know that the flushing is happening because he's getting a high temperature and you need to eliminate the heat. You will most importantly got the meiosis, that means a pupillary constriction, because you cannot dilate your pupils after this pathway is damaged. You will have a damage in the first neuron because of a pontine hemorrhage, because of a lateral medullary syndrome, because of any spinal cord lesion like the Brown-Séquard syndrome or the syringomyelia, late stage. You will have a damage in the second neuron because of any stellate ganglion compression, okay, or any sympathetic chain compression, I must say, and that can be happen because of a Pancoast tumor. You will have a third neuron damage, okay, and that can happen because of a carotid dissection, and this condition is very much painful. Okay, you will have an acute blood loss, you will have a shock, a hemorrhagic shock, which is very much painful. Along with that, you also have the Horner syndrome, right? So these are the damaging of the neurons, and these are the symptoms you will get. So patient will have the drooping of the eyelid, the flushing of the face, and the meiosis, the pupillary constriction. Okay. So with the first neuron damage, you will have other symptoms also, like the contralateral hemiparesis, hemisensory loss, right? With the second neuron damage, you will have some kind of a cancer history, or sometimes you will also have, the subclavian vein syndrome or the Supevina-Cava syndrome, right? You will have this edema of the face, the edema of the hands will be there. In case of third neuron damage, you will have a hemorrhagic shock and a painful condition along with the Horner syndrome. So that's how you will differentiate between all these conditions. Any doubt?
No, thank you.
Now, how can you differentiate? You need to make sure that you must know that you will only get the Horner syndrome in case of pan-cause tumor. Okay, with you have studied that with many of the mediastinal masses, you can have either the Supevina-Cava syndrome or the subclavian vein syndrome, right?
Yes.
But only in case of my pan-cause tumor, you can have this Horner syndrome. So whenever you encounter a patient who is having either the Supevina-Cava syndrome or the subclavian vein syndrome along with the Horner syndrome, think only about the pan-cause tumor. If you have just this Supevina-Cava or the subclavian vein syndrome, okay, then less chances are there that the patient is having a pan-cause tumor. It could be due to any mediastinal mass. Okay, so you must know that fact. You can have the Horner syndrome by the compression of the sympathetic chain only in case of the pan-cause tumor. Okay.
Yeah.
Okay, so that was about the Horner syndrome. Then you have the ocular motility. Okay, you have the extraocular muscles causing the eye movement. Okay, if I draw this eye, yeah, that's eye is now. See, whenever you have certain muscles, one is the superior rectus, you have the inferior rectus, you have the lateral rectus, and you have the medial rectus. Then you have two oblique muscles. One is the superior oblique, and second is the inferior oblique. Okay, and the function of the superior oblique is to cause the extorsion. That means the external rotation of the eye. Okay, the function of internal oblique is to cause the internal rotation of the eye. Okay, whenever your eyes are adducted, that means on the medial direction, the function of the superior oblique is to cause the downward movement of the eye. Are we good?
Yes.
And why is that happening? Because of the angle between the eyeball and the superior oblique muscle. In a normal position, if this is your eyeball, okay, the angle between my superior oblique muscle and the eyeball is 90 degree. Okay, so as you know, whenever this muscle constrict, it will cause the external rotation, right?
Yeah.
Whenever you adduct your eye in the middle direction, you will have the angle between the eyeball and this oblique muscle a 0 degree angle. Okay, they both will be parallel to each other. So in the scenario, whenever you constrict your muscle, you will have a downward movement of the eye instead of the rotation movement. Okay.
Yes. Yes.
So do note that fact. Either the external rotation or the downward movement. Similar goes for the inferior oblique. Either you can have a medial rotation or you can have a upward movement of the eye because of the constriction of this muscle. Okay. Now, most of the muscles are given by the third cranial nerve. Okay. Only the rectal rectus is given by the sixth nerve. Okay. And the inferior oblique, the superior oblique is given by the fourth nerve. Okay, and you can remember this mnemonic by this mnemonic like LR6, SO4, and R3. The superior oblique is given by the fourth nerve. Okay, the little rectus is given by the sixth nerve, right? And rest all of the muscles are given by the third nerve. Okay, so LR6, SO4, and rest of all are 3. That means the middle rectus, superior rectus, inferior rectus, and the inferior oblique are given by the third nerve. The lateral rectus is given by the sixth nerve, and the superior oblique is given by the fourth nerve. Okay. And yeah, that would be all about it. Any doubt on the extraocular muscles?
No, thank you.
Any doubt on this page?
Could you please explain what's highlighted there below that diagram?
The function of obliques.
Okay, yeah.
I
Yeah.
told you already.
Yeah.
The internal or the lateral rotation, or you can have the abduction or reduction, right?
Yeah, thank you.
Okay, now you have studied all the function of all these nerves, what the third nerve do, what the fourth nerve do, what the fifth nerve do. What happens whenever you got a damage of these nerves? The function of third nerve is two. One is to cause the contraction of these muscles, the extraocular muscles, and second is to cause the contraction of the pupillary sphincter muscle to cause the meiosis, right?
Yes.
So whenever you got a damage, you can have two things because you have two nuclei. Okay. In the periphery, you are having a parasympathetic nuclei. You call it a Eidinger-Westphal nuclei. In the center, you are having a motor nuclei. Okay. The blood supply will goes from periphery to the center. Okay. So in a scenario of ischemia or hypoglycemia, okay, the neurons of the motor nuclei will suffer first. In a case of any mechanical damage that can happen because of any tumor or because of any herniation, the peripheral neurons will die first, right?
Yes.
So in case of a ischemia, you will have a pupillary sparing. Okay, the motor fibers will affect more than the parasympathetic fibers. Okay, you can have an uncal herniation, and you guys already know you can have a comma because of that. You can have a posterior communicating artery aneurysm, and that can again cause the damage to the proximal area first. You can have a cavernous sinus thrombosis, and because of the cavernous sinus thrombosis, you can have an involvement of the fourth, fifth, sixth nerve, along with the third nerve also. So you will have a proptosis temporary. We'll discuss that about it later. Don't worry. Okay. You can have a midbrain stroke, and with the midbrain stroke, because this whole nucleus is present in the midbrain, you can have a contralateral hemiplegia. Okay, along with the vision loss. Sorry, along with this down and out movement of the eye. Okay, and the bilateral ptosis will be there. You have the motor nucleus, okay, which is a central one, right? And in that case, whenever you got any ischemia or the hypoglycemia, this motor nucleus will die first. That means in case of any vascular disease like the diabetes mellitus, okay, whenever your cell become deficient of the nutrition, okay, these motor fibers will die first. And because of that, you will have a ptosis and a down and out movement of the gaze. Okay, because all this lateral rectus and the superior oblique will dominate, right? They will cause a downward and outward movement of the eye because of the third nerve palsy. So a ptosis along with the down and out movement. So just remember, whenever you have any external damage, like any aneurysm, like any thrombosis, like any herniation or any trauma, you will have a damage of the peripheral nucleus, and as a result, you will lose the pupillary constriction. You will have a dilation first. In case of any hypoglycemia, hypoxia, or diabetes, you will have a damage of the motor output first. So it would be a normal pupil with down and out movement and ptosis. Okay.
Yes.
It's all about that only. In the parasympathetic, you can have a damage by the posterior disc artery aneurysm. You can have a damage because of the uncal herniation. You can have a damage because of this thrombosis, right? You will have an absence of the pupillary reflex. If the damage is more, you can have a damage of the motor nucleus also. In that case, you will have a full-blown pupil with down and out gaze. In case of my motor output damage, you will have a normal pupil with down and out gaze. Okay. So any doubt on third nerve palsy?
So in the parasympathetic output, you would be affecting the motor and the
And the parasympathetic itself?
yeah, because you're getting the blown pupil.
Yes. because on the peripheral fibers will die first because of any trauma, because of any herniation or any kind of a mass damage whenever happen, right? That will
Okay.
damage the whole nerve, or it will damage first your peripheral nucleus, then the central one. In case of any ischemia or any hypoxia, or you can say in case of a decrease in the nutrients, you will have a damage in the central nucleus first. That means the motor output will lose and you will have a normal pupil.
Okay, so what you're saying is in ischemia, the damage would be from the inside out versus if
Yes,
thrombosis, it would be from the outside in.
exactly. Opposite.
Okay, so in terms of an uncle herniation,
Yes.
the entire region is being affected. So
Yeah, the
both the inside
peripheral.
and outside is
Yes,
being affected.
exactly.
Okay. Versus in diabetes, that is a more vascular disorder.
Yeah, so you're having a
Um,
hypoxia.
okay. Okay,
In
because
that
okay.
case, yeah, in that case, motor nucleus will die only, the peripheral will survive, and you have a normal pupil, but a down and out movement of this eye will see, right?
Okay. But both of these are being done by CN3.
Yes, exactly.
Okay. Okay. Thank you.
Any more doubt?
No, thank you.
So just think damage can happen because of two things only, either the hypoxia or the external damage. If the external damage is there, okay, you will have you will have a loss of pupillary reflex. If the hypoxic damage occur, you will have the loss of only the motor output, the extraocular muscles. The pupillary reflex will survive because of these two presence of these two nuclei. Then you have a fourth nerve damage, and the fourth nerve supplying the superior oblique muscle, right? In that case, you will have a intorsion, right? No,
Yes.
because of a damage of my fourth nerve, I'm gonna have an intorsion of my eye. Okay, because the function of my superior oblique is to cause the extorsion, right?
Right.
So in that case, let us say if this is my right eye and this is my left eye. Okay, if I have any damage in my left eye, let's say, okay, the superior oblique got died, and as a result, I will have the this intorsion of the eye. My eye will become intorsed, right? Like that. Okay, and my this eye is normal. It can go anywhere I want, right? In order to correct the diplopia, I need both the eyes to be in the same direction. But because my eye is deviating in this direction, if I move my head on the this side, that means on the affected side, I will have this kind of a movement of the normal eye, right?
Yes.
And as a result, I will correct the diplopia. So the patient will present you with the tilting of the head, okay, to compensate for the this lack of intorsion in the affected eye. Just give me a second. There's some confusion, I think. Okay, there was a confusion. Like the superior rectus, sorry, the superior oblique will cause the intorsion, not the extorsion. Okay.
Okay.
You guys can hear me?
Yes.
Yeah. So the superior oblique will cause the intorsion, and the inferior oblique will cause the extorsion. right? So in that case, let me go back. If this is my eye and I have a damage of the this superior oblique, in that case, I cannot cause the intorsion, and as a result, my eye will become extorted, right? The affected eye will become extorted like that. In order to correct that, if this is my normal eye, I need both the eyes to be in the same direction. So in order to move this eye this side, I need to move my head on this side, right? When I move my head on this side, I will have a direction like that. Okay. So a normal patient is like that. And a patient who is having the damage of the fourth nerve, they will tilt their head like that. Okay.
Yes.
And the head tilting, as you can see, will be on the contralateral side. If this is my ipsilateral side, that means the left side which got damaged. This is my contralateral side. So the head tilting will be on the contralateral side, you will see. Okay. That is the important thing. The other function of my fourth nerve, the other function of my superior oblique is to cause the downward movement, right?
Yeah.
Because of this fourth nerve palsy, the patient cannot look downward, and that's why they will have a difficulty on reading the newspaper. They will have a difficulty on going downstairs because they cannot look downwards. So they will have a difficulty going downstairs, but they have a normal, they won't have any difficulty going upstairs, right? They will go normally. In case of my downstairs movement, they will have a diplopia, they will have a blurring of the vision. While reading the newspaper, they have a diplopia. Okay, rest all the movements are normal. So it would be a patient who's having a difficulty while reading or difficulty while going downstairs. They have this head tilting, right? And you will think about the fourth nerve damage after that. Okay, any doubt?
No, thank you.
Okay, then you
And
have
then
yes.
for the fourth and the sixth nerve, they only have their the motor function, right? Like there's no
Yes.
other.
They are purely motor muscle.
Okay,
Sorry,
thank you.
the purely motor nerve.
Okay,
So
thank you.
you have the sixth nerve supplying the lateral rectus. Whenever you have a damage of this nerve, you can have a medial deviation of the eye, right?
Yeah.
So you cannot abduct your eye and you will have a medial rotation instead. That's about the sixth nerve damage. So that's on the damage of my third, fourth, and sixth nerves. Any doubt?
No, thank you.
Okay. And I already told you about this efferent pupillary defect, right? Whenever you have a third nerve damage, if you shine the light on either of the eye, the pupillary constriction will be there in the ipsilateral to the eye which is not damaged, and the other eye, right? Beyond. Okay, in the affected eye, you cannot get either the direct response or the indirect response, while in the normal eye, you will get both that direct response as well as the indirect or the consensual response. That will be on the efferent pupillary defect. With the RAPD, the afferent pupillary defect, you will have this normal consensual and direct response when you shine light in the normal eye. When you shine light in the affected eye, you won't have any of the direct and the indirect response. Okay, that's how you will differentiate between the RAPD and the REPD.
So that's different from Marcus gun pupil?
Yeah, of course. The Marcus gun pupil is the afferent pupillary defect. That means a damage in the second nerve. Okay, but the efferent pupillary defect is a damage in the third nerve. Okay.
Oh.
In the causes we have discussed about this parasympathetic output, like the herniation, okay, or the aneurysm or any kind of a trauma, you will have this defect, the efferent pupillary defect.
Okay. Okay.
You're not getting right?
I'm a little confused, but I might have to go over this by myself too.
Let me explain one more time. For the light reflex, you need two things. One is the second nerve and one is this third nerve, right? The third cranial nerve. Okay.
Okay.
When you shine the light, the information will travel with the second nerve. After the second nerve, the information reaches to the pedictal nuclei. It will stimulate my third nerve to cause a constriction bilaterally, right? Direct as well as indirect. Okay.
Yes.
If you have a damage in the second nerve, that is a relative afferent pupillary defect, you cannot have the sensing of the information whenever you shine the light.
Yes.
If you shine the light in the normal eye, both the direct as well as the indirect response will occur because the third nerve is normal. So both the nuclei will be stimulated, right?
Mm-hmm.
If you shine the light in the abnormal eye, you cannot have any traveling of the information, and as a result, none of the eye will constrict.
Okay.
In case of a third nerve damage, okay, if you shine the light in the normal eye, it will have a normal constriction, direct one, but the indirect constriction won't happen because you require a third nerve to do that, right?
Oh, okay. So the third nerve is involved in the consensual response.
Of course, it is this Edinger-Westphal nucleus.
Okay.
It was
So
a third
it's
nucleus. Yeah, it was a third nerve nucleus, which is for the for this efferent pathway.
okay. So it is getting the information, but the nerve is not able to respond.
Exactly.
Okay. Versus in the
Because
second, yes, you
yeah,
never get the information in the first place.
exactly. In the second damage, you never get the information. In the third damage, you are getting the information, but you're not doing anything with that. The output is decreased. In case of my second nerve damage, the input is lost, right?
Yes. Okay, I understand now. Thank you so much.
So let's take a break and then start these visual field defects, okay?
Yes. Thank you.
Okay, so let's begin the visual field defects. For that, first you need to know about the visual pathway, the visual field pathway. Okay, so you have the eyeballs. Okay, the retina. Okay, so whenever the light is present in the middle direction, in the mid, okay, it will form on the lateral retina. Okay, from there, the information is carried by the medial fibers. Okay, regarding my point, let me open a diagram. It would be much easier for you. Just give me a second. Okay, see. All the information from the middle vision, okay, or you can say from the left side of the vision, okay, it will be falling on the right sided retina. The information from the right sided retina, it will be taken by the lateral fibers, as you can see. Okay, the lateral information, it will be falling on the medial side of the retina. Okay, and the information will be traveled by the medial fibers. Similar case here, the information on the medial side, all the light, all the objects that are transmitting light from the medial side, it will fall on the lateral retina. Okay, the fibers will be taken by the lateral fibers, this information. For the lateral side view, all the information will be falling on the medial side retina, and the information will be taken by the medial fibers. Okay, the medial fibers will cross over. Okay, and the crossover portion is known as the optic chiasm. Okay, so now you have two pathways, okay, two-sided pathways. One is the right side and one is the left side. Both of them will go to the lateral geniculate body. These are the lateral geniculate body. Okay, from there you have two optic radiations, one in the parietal lobe, okay, and one in the temporal lobe. Okay, both the information from the parietal lobe and the temporal lobe, it will ultimately reaches to the visual cortex, which is present in the occipital lobe. Is that okay?
Yeah.
Yes.
So now let's go back to the first aid again. So as you can see, you have this retina. Okay, the medial fibers will cross over, and then you have two tracts. Okay, the right sided tract and the left sided tract. Okay, you have two radiations after the lateral geniculate body, as you can see. Okay, the fibers which are running in the temporal lobe, you call them the Mayer's lobe. Okay, and the fibers which are running in the parietal lobe, you call them the dorsal optic radiation. Okay, these fibers will carry the information on the lower part of the retina, and the fibers in the temporal lobe carry the information on the upper part of the retina. Okay, and finally, all these fibers will reach to the your visual cortex, which is the occipital lobe. Okay, now, so all the information on the all the objects which are present on the upper part, the information from that object will fall on the lower retina. The objects which are present in the lower part, all the information from them will fall on the upper part of the retina. The objects which are in the middle, the information will fall on the lateral retina, and the objects which are lateral, the information will fall on the medial retina. Always opposite. Okay. So first you have a damage of this optic nerve here from the individual eye. In that case, you will have a loss of complete this visual field from one eye. Okay, and you call that a monoocular loss of vision. Okay, first thing. Second thing, you have a damage in the optic chiasm. Okay, and that can lead to the bitemporal hemianopia, or you can call it a bitemporal hemianopsia also. Okay, it can happen because of any pituitary lesion, because the pituitary gland is present just above it. Okay. Third is a damage after a crossing over. Okay, and because the fibers which are crossing over from the middle direction, they will be carrying this information, right? The information from the middle of the retina, right? And that means on the lateral part of any object, the lateral object. Okay.
Yeah.
And similarly, the fibers which are not crossing over in this direction, they will be carrying the information from the middle object. So whenever you have any damage in this part after the optic chiasm, you will have something known as the homonymous hemianopia. This homonymous hemianopia. Okay, that means you will have a loss of vision on the same side on both of these retina. If it is a left homonymous hemianopia, that means a damage is happening in the right part. If it is a right homonymous hemianopia, that means a damage is happening on the left part. Is that okay? It will always be a contralateral homonymous hemianopia. Okay.
Yeah.
You can have this homonopia by the MCA stroke, and the middle cerebral artery stroke can cause it. Okay, very important. Fourth, you have the quadrantopia, and these are of two types. Okay, either the upper quadrantopia or the lower quadrantopia. The upper quadrantopia, you call it a pie in the sky. You can remember it like that. And the lower quadrantopia is known as a pie on the floor. Okay. See, the Mayer's loop, it will be taking all the information from the upper part of the retina. That means, from the lower part of the retina. That means all of these objects which are present superiorly, their image will fall on their light will fall on the lower part of the retina, right?
Yeah.
So because of a damage in the Mayer's loop, you will have this pie in the sky. It will be a homonymous quadrantopia. Left upper quadrantopia, I will call it, in case of any temporal lesion. Similarly, the parietal lobe will carry the information from the upper part of the retina. That means all the objects which are present below my eye, their image will fall on the upper retina, and then they will travel via the dorsal optic radiation. When this part dies, you will have a lower quadrantopia homonymous. So a contralateral lower quadrantopia, homonymous quadrantopia, In case of this, the damage in the temporal lobe, you will have a upper chordontopia, homonymous. Okay, and that can happen because of a middle cerebral artery stroke. Both of these can be happening due to the MCA stroke. Okay, then you have the left homonymous hemianopia with a macular sparing, and that happens whenever you get a damage in the occipital lobe directly. Okay, the macula, it has dual blood supply. Okay, the regions which are supplying the macula, they also have dual blood supply. That means in a scenario where you have this occipital, the artery supplying the occipital lobe, that means a PCA. Okay, so it will lead to a damage of all this visual cortex, but the part which is supplying the macula, it has dual blood supply, and as a result, you will have a macular sparing. As you can see, it will be a homonymous hemianopia with a macular sparing because of a dual blood supply. So even macula has a dual blood supply in the retina, and the centers, okay, which are carrying all the fibers for the macula, they also have a dual blood supply. Okay.
Yes.
Then you have the center scotoma. Okay, whenever you have any damage directly to my this retina, the macular damage will happen most commonly, and that will lead to the central scotoma, and that happen most commonly in the age-related macular degeneration. Okay. Yes. ARMD, remember?
Yeah. So central scotoma usually does not involve a damage to the nerves, right?
Central scotoma actually is nothing but a nerves, a collection of nerves.
Yeah.
Macula is nothing but nerves, right?
Yeah. Basically, no damage to the brain actually in central.
Yeah,
scotoma.
exactly. Yeah, exactly. No damage to the brain. It's happening in the retina only due to any hypoxia or something like that. Okay.
Okay. Okay. Thank you.
So Mayer's loop carrying the fibers from the lower retina. Okay. And the dorsal optic radiation carrying the fibers from the superior retina. Okay, do remember that. So step 1 will give you a scenario where the patient is having any aneurysm or having any pituitary tumor or having any stroke in the MCA or having any hypoxia in the retina, and they will ask you what kind of a visual field defect the patient can have, and you have to remember all the examples, okay, and all the reasons of all these visual fields defects. Is that okay?
Yes.
Yes.
Okay, so yeah, that's all about the visual field defects. Any doubt? Any doubt on the visual field defects?
Someone has texted a question in the chat box.
Okay, let me check. 6. Okay. You're talking about the this macro sparing, right? See, in your occipital lobe, you have this visual cortex. Okay, and all the information from the optic nerve ultimately reaching to the visual cortex, and then the visual cortex will use this information and will form an image. Right now, you have two parts in the visual cortex: one supplying the peripheral vision and one supplying the medial vision. Okay, now the part which is supplying the medial vision, that means the macula, it has dual blood supply. So in the scenario where you have any stroke in the posterior communicating artery, all of the region of the visual cortex will die except the part which is supplying the macula, and that's why you will have a macular sparing whenever you have a posterior the cerebral artery stroke. Is that what you're asking? Okay. Any more doubt?
No, thank you.
Okay, and finally you have the cavernous sinus. Okay, you have to remember this figure. They will ask you this. I think I got this exact figure on my exam. Okay, and even 2 or 3 NBMEs has this kind of a figure. So you need to remember where the nerve lies actually, right? So this cavernous sinus present around the pituitary, as you can see. Okay, it has arteries like the internal carotid artery. Okay, and please note you have two branches of the internal carotid artery. One is present in the cavernous sinus and one present outside the cavernous sinus. Okay. Remember all this. If you go back to the anatomy part of the neurology, we have discussed all the openings for the nerves, right? That exits my skull.
Yes.
Yes. And I told you about the superior orbital fissure and the optic canal, right?
Yeah.
So all these nerves, okay, from the superior orbital fissure, right, and the nerve from the foramen, this rotundum, they will ultimately enter into the cavernous sinus. That means the kernel of 3, nerve 4, nerve 5, 1. That means the this ophthalmic division of the trigeminal nerve, and the abducent nerve, 6 nerve. They will enter into the superior orbital fissure, right?
Yeah.
And the maxillary nerve, okay, it will enter into the what foramen?
Rotundum.
Rotundum. So all of them finally enter into the cavernous sinus, and then they will reach to their respective location. In a scenario where you have any thrombosis in the cavernous sinus, all of these nerves will suffer. Whenever you have any aneurysm in the internal carotid artery, okay, the abducens, this abducens nerve, which is a 6th nerve, it will suffer first. As you can see, it is lie very close to the internal carotid artery, right? So whenever you have any aneurysm in the internal carotid artery, this nerve will die first and then the rest of the nerves. Okay.
Yes.
Yes.
Along with that, you guys know that, all the sympathetic fibers for the pupillary dilation, they also runs in this part, in the cavernous sinus. Remember the descending hypothalamic tract?
Yes.
Okay. So the nerve 3, 4, 5, 1, 5, 2, and 6, and the postganglionic sympathetic pupillary fibers, they all run into the cavernous sinus. Whenever you have a cavernous sinus syndrome, it will lead to the ophthalmoplegia because of the kernel of 3, kernel of 4, kernel of 6 defect. You will have a decrease in the corneal sensations because of a 5th one, which is the ophthalmic division. It will die. You will have a Horner syndrome. Okay. You will have a decreased maxillary sensations because of this maxillary part of the trigeminal nerve. And that can be happen because of any tumor mass effect. Pituitary tumor can do that. As you can see, pituitary is lie in the center of this cavernous sinus. So any tumor can affect this condition, can cause this. Any cavernous carotid fistula can cause it. You will have a blood-filled area, hemorrhage in the cavernous sinus that can lead to the damage of all these nerves. You can have a cavernous sinus thrombosis with an infection, and the most common cause are the mycorrhizopus, streptococcus, and the staphylococcus aureus. Staph aureus is the most common. Okay, then you have the mycorrhizopus and then the streptococci. Okay, if you guys remember, the mucor and rhizopus can infect only the diabetic ketoacidosis patient and the immunocompromised patient, right?
Yes.
And they will cause all the damage of your sinuses. It will cause a bleeding into the sinus. Necrotic scar will be formed on your around the eyes, on the nose, right?
Right.
From there, the infection can reach to your brain and then to the cavernous sinus, and there they can damage the cavernous sinus, causing all the symptoms. You will have, the full-blown pupil will be there, right? Sorry, yeah, not the full-blown pupil, but you have a constricted pupil, right? You will have, a loss of all the innervation of all the muscles in the eye. So it will be a fixed constricted pupil you will see, right? You're having, this loss of senses over the eye. You will have a loss of senses over my face. That are the symptoms of the cavernous sinus thrombosis or any infection or any fistula. Okay. Are we good?
I have one question.
Yes.
Since the oculomotor nerve is also carrying the parasympathetic fibers and the internal carotid artery is carrying the sympathetic fibers, like
Yeah.
so we get the Horner syndrome, like the normal Horner syndrome, or is there any, like, can there be a pupillary dilation also?
This third nerve is not carrying the sympathetic fibers. It only carrying the parasympathetic fibers, right?
Yeah.
Horner syndrome will be there, and that will lead to this meiosis only.
Right.
In case you're having a damage, if the complete damage occurred, that include all the third nerve, right, including all the motor nucleus as well as the Edinger Westphal nucleus, right? If that happens, you will have a fixed pupil.
Okay.
It cannot move. Your eye cannot move in any direction. Your pupil cannot move at all, right? If you have the Horner syndrome, that will only damage the this postganglionic sympathetic pupillary fibers. In that case, your third nerve was normal. You will have a constriction, meiosis.
Yeah, yeah. So
Okay, so
it basically depends on which nerve fiber is getting damaged.
exactly, it depends on which nerve fiber is getting damaged.
Okay, okay. Thank you.
Depends upon the severity of the disease ultimately.
Right.
In case you have the aneurysms, you will first have a damage in the sixth nerve, and then at the very end you will have a damage in the third nerve, right? After all of these nerves got damaged, as you can see, distance is very much enough, right?
Right. Yeah.
So it depends upon the severity of the disease, cause of the disease. All of these things will cause all these symptoms. But just know that the third nerve, fourth nerve, 5, 1, 5, 2, and sixth nerve, they all passes through the cavernous sinus in the order third, fourth, 5, 1, 5, 2, and 6. Okay, symptoms will be like correspond to these nerves only. So any doubt on the cavernous sinus?
No, thank you.
No, thank you.
Okay, now you have the final topic of the ophthalmology, and that is the intranuclear ophthalmoplegia. We have discussed that already. See, whenever your cortex got activated for a gaze movement, it will transmit the signals to my pons, the contralateral pons. From the contralateral pons, you will have the PPRF, parapontine reticular formations, and they will cause two things. One is the activation of the ipsilateral sixth nerve nucleus, and second is to transmit the fibers via this MLF, the contralateral MLF fibers, as you can see. That means ipsilateral to my cortex, right? And that leads to the activation of the ipsilateral third nerve. Whenever the third nerve got activated, it will cause the constriction of this, the contraction of my medial rectus, so that you will have this right-sided movement, right? When my pons got activated, the sixth nerve, you will have a contraction of the lateral rectus, and that again move the eye on the lateral side or the right side, right?
Yeah.
So with the left cortex activation, or let's suppose if it is a right frontal eye field, you're gonna have a movement of the eye on the left side. If it is a left-sided frontal eye field, you will have a movement of the eye on the right side, the contralateral always, right?
Yes.
Whenever you have an activation of the PPRF, it will move the eye on the ipsilateral direction. Whenever you have the activation of the third nerve, the MLF, whenever you have the activation of the MLF, they will move the eye on the contralateral side, right?
Yes.
Now look off all these lesions now. So you have the MLF, which are basically a pair of fibers that connect the sixth nerve to the third nerve nuclei. They are highly myelinated, and that's why the information travels very quickly, which of course you need in order to move your eyes, because the fibers have to travel from sixth nerve to third nerve, from the pons to midbrain, so that this delay must be decreased, right, in order to get a coordinated movement, and that's why the fibers needs to be highly myelinated. Whenever you have a lesion in the MLF, okay, if this MLF got damaged, when the cortex want to activate a gaze, it will cause this contraction of the lateral rectus, so the contralateral eye will move, but the ipsilateral eye, it won't move, right? And that causes an nystagmus. Okay, as soon as this eye moves, you will get a diplopia. Your brain will realize that it is a misalignment. It will try to correct the normal eye to the medial side again, and that will cause an nystagmus, the correction. So it will be a rapid correction on the medial side, right? Conjugate gaze pulse will be there, lack of communication. Okay, when the sixth nerve nucleus activates the ipsilateral lateral rectus, the contralateral third nucleus does not activate the medial rectus, and as a result, you will have a this abducting eye that will display the nystagmus. Okay, very important. The convergence, it will be normal. See, because this MLF only required at the time of gaze movement. Okay, when you're doing the convergence movement, okay, in that case, this cortex directly activate the third nerve. Okay, the frontal eye fields will directly activate the third nerve, and that will move the eye at the same time. So you do not require the MLF in case of this convergence movement, right? So convergence will be normal. It just the gaze movement will cause the nystagmus. Are you getting my point?
Yes.
Could you repeat, please?
See, in case of convergence, the cortex, okay, the frontal eye field will directly activate the third nerve. Okay, like it will directly activate the third nerve without the need of this MLF or the PPRF. Okay. In that case, because I do not require the MLF, the convergence will be normal, but I got a defective gaze only. It's still not okay.
Okay, yeah, okay.
Okay.
Yes, okay.
Now, so that was about my intranuclear ophthalmoplegia, and that most commonly happens in the multiple sclerosis, right?
Yes.
So when looking left, the left nucleus of the sixth nerve fires, which contract the left little rectus, okay, which you guys have already seen here. Whenever the left nucleus activated, we cause the activation of left little rectus. At the same time, it will also send a signal onto the contralateral MLF, okay, that causes the contraction of the right middle rectus. So you're having a contraction of the left lateral rectus and the right middle rectus. Okay, that is the normal scenario. Okay, so in the eye, you're having a ipsilateral adduction failure. Okay, ipsilateral adduction failure. Okay, and the nystagmus will be happening in the opposite side. Okay, because this eye will move, your brain will detect it and it will try to converge it again, right? It will try to adduct it again, so this will cause a nystagmus, right?
Yes.
So that was about my intranuclear application. Just know that it will be a contralateral part of my cortex that will cause, if it is my right cortex, it will cause the contraction of my left a little rectus, okay, and the right middle rectus. So you will have an opposite movement or the contralateral gaze always, right? And MLF causes the ipsilateral medial rectus contraction. PPRF will cause the this ipsilateral type of side of movement, right?
Yes.
So that's everything on the INO. Any doubt?
No, thank you.
No, thank you.
Okay, so we are done with the ophthalmology, and now let's start the pharmacology. Just give me a second. Okay, so pharmacology. First, you have the drugs for the epilepsy. We have discussed that already. Whenever you have any partial seizures, whether it's a complicated or a non-complicated type, you can give the patient all this carbamazepine, right?
Yes.
And you cannot use these drugs whenever you have a generalized type of seizures, right? But those seizures which will become generalized after the this partial seizures, when the partial seizures become the generalized seizures, in that case you can use a carbamazepine, right?
Yes.
But if the seizures are generalized at a very initial, that means you have to use other agents like the lamotrigine or the valproic acids. So first you have the benzodiazepines, okay, and the benzodiazepines action is to activate the GABA A type channels. So that will cause a chlorine influx, and as a result, the inhibition of the neuronal firings, because it is a inhibitory neurotransmitter, right? You can use these agents for the status epilepticus. And what is the definition of a status epilepticus?
A new seizure within
More.
5 minutes.
5 minutes.
Yes, a new seizure within 5 minutes, and before the patient before the patient regains its consciousness, right?
Yeah.
So in that case, whenever you have a recurrent episodes of all this epilepsy without regaining this full consciousness, you will call it as status epilepticus. In that case, you have to use the benzodiazepines in a very acute scenario. Okay. Side effects again: sedation, tolerance, dependence, respiratory depression. Right. You will hear them later in the psychiatry again. So don't worry about that. No, not in the psychiatry, but in the later pages. Okay. Then you have other uses of the benzodiazepines also, like the eclamptic seizures. You can use them. Although the first line therapy for the eclamptic seizures are the magnesium sulfate. If the magnesium sulfate is not available, you can also use the benzodiazepines in the patient. Okay. Then you have the carbamazepine. Okay, and that blocks the sodium channels. Let's discuss all these pathways first here, right? All these epilepsy. So why this epilepsy is happening? Because of a rapid firing of the neurons, right?
Yes.
So ultimately, you need to inhibit the neurons from firing. And that can be done by increasing the negative charge inside the neurons. Okay. So first we have the sodium channel blockers that will inhibit the entry of the sodium channels. And as a result, the depolarization will be prevented. If you do not have depolarization, then you do not have a release of any of the excitatory neurotransmitters like the glutamate. In that case, you will have an inhibition. Second type are the calcium channel inhibitors. Okay, like the ethosuximide or the gabapentin, they will inhibit the calcium channels because after the sodium, you need the calcium influx to cause the release of all these neurotransmitters, right? So if the calcium is not there, the release won't happen. Then you have the SV2A receptor blocker. You need these receptors for the vesicles to fuse with the membrane. If the receptors is not present, you won't have any fusion, so you won't have any release of the receptors. The release of the neurotransmitters. So SV2 receptors blocker, that is the levetiracetam, right? It will inhibit the fusion ultimately. Okay. So these are all the agents which are acting on the presynaptic neurons. Okay, and they're inhibiting the ultimately release of all the neurotransmitter. Now, once the neurotransmitter is released, now you need to inhibit the response of the postsynaptic neuron. That means you require all the GABA agonist, because whenever the GABA is there, it will cause the hyperpolarization or the negative charge build up inside the neural tissue, and that will inhibit the response. Okay, like the benzodiazepines. Topiramate can do that, which is also a sodium channel blocker. Phenobarbital, propofol can do that. Okay, then you have agents which will inhibit the metabolism of my GABA. Okay, and these are the tiagabin. Okay, it will inhibit the reuptake of my GABA. You have the valproic acid, which is again a sodium channel inhibitor, also an inhibitor of GABA transminase. Similarly, vigabatrin. Okay, and these drugs inhibit the GABA transminase, so inhibiting the metabolism of my GABA. So the GABA concentration will be increased, and you will have a more chlorine influx inside the cell. Right. So these are all the therapies that we will give for the epilepsy. Okay. Any doubt on any of a mechanism?
Could you please explain the use of SV2A receptor over here?
See, the function of the receptors is to cause the fusion of these vesicles filled with the neurotransmitter with the membrane. Without fusion, you cannot have a release of any neurotransmitter, right?
Okay, yeah.
So
Yes.
they inhibit this fusion ultimately.
Okay, so similar to Botox.
Yeah, similar to Botox. In case of Botox, even if they fuse, you require the snare proteins to release them. So
Right.
Botox inhibiting the snare receptors.
Yeah. Okay, thank you.
So let's discuss their uses now. So we have discussed the benzodiazepines. Okay, now comes the carbamazepine, which is a sodium channel blocker, right? So the most common use it will be in the partial or the focal seizures, or these partial seizures, whenever they become generalized seizures, you can use the carbamazepine, right? Side effects are a must remember thing. One is the inhibition of your bone marrow. It will cause the agranulocytosis and the aplastic anemia. That means you can get a pancytopenia. In a very simplistic way, you can say it will cause the pancytopenia. Okay, you will get a spina bifida. That means all these uh, the defects which are associated with the loss of vitamin B9, right?
Yeah.
The neural tube
Yes.
defects you can get. Okay, it will also induce a cytochrome P450, which makes sense. I told you already, all the CNS drugs will cause the activation of P450, right?
Yes.
So they will activate the P450, and one of the most important thing you will get from the carbamazepine is the SIADH. And that is the important. So a pancytopenia and the SIADH with cytochrome P450 activation. These are the three most important side effects you must remember. Okay, Stephen most commonly asks you only these three. Okay, and you can use them for the trigeminal neuralgia. If you guys remember the shooting, stabbing like pain, electric shock like pain, right?
Yeah.
You will get, so for a treatment of that, you will need to give the patient the carbamazepine. Other use is the bipolar disorder. We will discuss that. You have three type of bipolar disorders. Okay, so for the treatment of that, you can give the patient carbamazepine. Okay, then you have the ethosuximide, which is a calcium channel blocker. Okay, and you use that mainly for the absence seizures. And you guys already know how to differentiate between the absence seizure and the partial complicated seizures, right?
Yes.
So for the absence seizures, you need to give the patient ethosuximide, the drug of choice. But the ethosuximide can cause the Stevens-Johnson syndrome. Okay, that is the important thing. Just give me a second. Okay, welcome back. Yeah, sorry about that. So for the ethosuximide, you will inhibit the calcium channels, right? And you're using them for the absence seizures. Okay, and the side effect include the most commonly Stevens-Johnson syndrome. Then you have the gabapentin, and it is an anti-epileptic drug, but you use this gabapentin mainly for the neuropathic pain. Okay, the most common use is the neuropathic pain and the post-herpetic neuralgia. Okay, it is again just like my ethosuximide, calcium channel blocker. Then you have the lamotrigine. Okay, and it is a kind of it is a very wide action. Okay, it can be used for the partial focal seizures, for the tonic-clonic seizures, for the absence seizures. So a wide spectrum drug it is. It inhibits the sodium channels, and that's why it inhibit the release of glutamate, which is a excitatory neurotransmitter, right?
Yeah.
Yes.
And lamotrigine has a most common side effect, that is the Stevens-Johnson syndrome. If you guys remember the mnemonic SLAP, I hope. What other drugs can cause the Stevens-Johnson syndrome?
Vancomycin.
Vancomycin can cause the Stevens-Johnson syndrome. I don't think so.
Sorry.
The sulfonamides, lamotrigine, allopurinol, phenytoin. Remember? SLAP. So these are the four most common drugs that can cause a Stevens-Johnson. Step 1 can ask you these 4 drugs, okay? So the lamotrigine can cause the Stevens-Johnson syndrome, and it can also cause the hemophagocytic lymphohistiocytosis. Okay, and does anyone remember what this disorder is? We have discussed that in the hemonc.
Macrophages and T cells get activated.
Yeah, macrophages and T cells will get activated, and they will start phagocyting all these RBCs, right, in the liver, in the spleen, in the bone marrow, right? You will have a pancytopenia because of that. Okay, so remember the Stevens-Johnson syndrome and the hemophagocytic lymphohistiocytosis. You can use a lamotrigine for the bipolar disorder. Okay, again, just like my carbamazepine. Then you have the levetiracetam, the SV2 blocker, SV2A blocker. Okay, and you can use them for the tonic-clonic and the partial seizures. Okay, and you use this drug mainly for the epilepsy in the pregnancy because it is a safe drug for the pregnancy. Okay, although it can cause some neuropsychiatric changes like the personality change, fatigue, headache, doesn't matter. Okay, doesn't necessarily important. Just know that the levetiracetam is actually a SV2A receptor blocker. Then you have the phenobarbital. Okay, and the phenobarbital is actually a first-line therapy in the babies. Whenever you have any epilepsy seizures in the babies, you will use the phenobarbital. Okay, and except the absence seizure, you can use them anywhere. Okay, so excluding the absence seizure for partial, complex, generalized, tonic-clonic, or myotonic, or any kind of a seizure, you can give the phenobarbital. It is just like my benzodiazepines, a GABA A agonist. So it will cause the hyperpolarization, inhibition of the neurotransmission. It will induce the cytochrome P450, right? And it is a first-line therapy in the neonates, in the babies. Then you have the phenytoin and the derivative phosphanytoin. Like my phenobarbital, it can be used anywhere except the absence seizures. Okay, it will inhibit my sodium channels. Okay, and it is a drug which can go for the zero order kinetics. Okay, and does this drug has zero order kinetics at any concentration, or does this drug become the zero order kinetics at a very high concentration only?
At higher concentration.
At higher concentration only. And why is that so?
The saturation of the transporters.
Yeah, all the enzymes, right? You have the enzymes, they have a certain limit. After that, they cannot metabolize any further. So even if you increase the concentration, the rate of the drug excretion will be same, right? So a constant amount will be eliminating at a particular time. Okay, doesn't matter what the concentration is. So you use that drug mainly for the for any kind of a seizures except the absence seizures. And the side effects of the phenytoin are, must remember, you have the activation of the cytochrome P450. It can cause the hirsutism in the females. You can call it can cause the bleeding gums and the enlarged gum. You will have a gum hypertrophy, I must say, right? And that is an important thing. Whenever a patient take the phenytoin, after some time of use, you can have the hypertrophy of the gums. Nystagmus can happen. Yellow brown skin discoloration can happen. It is a highly tergenic drug, so must avoid in the pregnancy. It can cause the fetal hydantoin syndrome, in which you have the orofacial cleft, the cleft lip and palate. You can have, right? You can have a microcephaly. Okay, and the digit hypoplasia and the nail hypoplasia is the important one. Okay, so abnormal facial features. Okay, digit or nail hypoplasia and the microcephaly you will get whenever you give the patient phenytoin in the pregnancy. Okay, it can also inhibit the folate absorption, and as a result, it can cause all the neural tube defects. Okay, it can cause the rarely Stevens-Johnson syndrome, but it is 4 of the most common causes of the Stevens-Johnson syndrome. It can also cause the dress syndrome. See, it is not a Dressler's, it is a dress syndrome. Okay, and what does a Dresser syndrome?
Post myocardial injury, pericarditis.
And how does this pericarditis happening post infarction patient?
Autoimmune condition.
Autoimmune phenomenon.
Autoimmune. It is an autoimmune condition, right? So in case of my dress syndrome, it actually happens because of the IgE antibodies. Let's discuss that dress syndrome. This condition happens after a month use of the phenytoin. Okay. Other drugs like the carbamazepine can also do that. Sulfasalazine can do that. Antibiotics, the allopurinol can also. That means all the drugs that can cause the Stevens-Johnson syndrome, they can also cause a Rett syndrome, I must say. Right. And it happens because, although the mechanism is not very much clear, okay, but some suggest that this condition is happening because of the drug-induced activation of the herpes virus. Okay, and the cross reaction against the T cells. Okay, the patient will have the fever, they will have a generalized lymphadenopathy, and this lymphadenopathy involving a majority of your body. Okay, you will have a facial edema and a skin rash. Okay, and the rash must be involving more than 50% of the body. It will be a reddish kind of rash. Okay, and it involve more than 50% of the body. Other signs of organ damage would be there, like the liver damage. You will have a hepatomegaly, jaundice, high ALT, AST count in the kidney. You can have a acute interstitial nephritis that can lead to a high creatinine count and the oliguria. Patient can have some cough and dyspnea in the lungs because of the fibrosis. Okay, patient on the laboratory findings, you can have a eosinophilia, atypical lymphocytosis, and high ALT AST, and the treatment will be the withdrawal of the drug. So it will be a patient having a history of epilepsy, now presenting to your department with this generalized swelling in the body and a reddish rash occupying more than 50% of the body area, and staff will ask you, what can you find on the lab on this lab examination? What drug can be causing it? So you must know it is the phenytoin, and you will have the eosinophilia in this condition. Okay, any doubt?
No, thank you.
So that's about my Rett syndrome. So the major side effects you must remember: one is the cytochrome P50 activation. Second major one is the gum hypertrophy. Third major one is the Rett syndrome. Okay. Fourth one is the folate inhibition, and the teratogenic effect is the fetal hydantoin. Only these 5 side effects, the major ones you must remember. You can forget that yellow-brown discoloration, nystagmus, right? They are not the important ones. The important ones are the P50 induction, enlarged gums, okay, and the fetal hydantoin syndrome, folate inhibition, and the Rett syndrome. These are the important ones you must remember. Any doubt on phenytoin?
No, thank you.
No, thank you.
Okay. Then you have the topiramate. Okay, it can be used for the partial seizures as well as the tonic-clonic seizures, blocking the sodium channels and activating my GABA, just like the benzodiazepines. Okay, and the topiramate, the most common use is in the migraine prophylaxis. If you guys go back to the headache part, we have discussed that the topiramate, right, and this valproic acid, they can be used for the treatment of migraine, right?
Yeah.
Then you have the valproic acid, and it is again a wide spectrum drug. You can use this drug anywhere except the status epilepticus, because in case of the status epilepticus, you need to give the patient either the benzodiazepines or the phenytoin. And please note, whenever you encounter a patient having these episodes of the status epilepticus, in that case, you have to give the patient benzodiazepines first. And once the patient is stabilized with the benzodiazepines, then for the chronic therapy, you must use the phenytoin. So after stabilizing the patient, you will switch the patients to the phenytoin, okay, for the chronic treatment. Is that okay?
Yes.
So the valproic acid, it can be used anywhere in any kind of seizure: myoclonic, absence, partial, tonic-clonic, except the this status epilepticus. So it is a very wide spectrum drug, inhibiting my sodium channels active, and as well as inhibiting the metabolism of the GABA by inhibiting the GABA transaminase. Right? You must remember all these side effects of this valproic acid. It can cause a hepatotoxicity. Okay, it can cause the pancreatitis. It can cause the neural tube defects. Okay, and these 3 are the important ones. And that's why you cannot use this drug in the pregnancy. And if you're using this drug in the pregnancy, then you must give the patient vitamin B9 to prevent the neural tube defects. This drug can also cause the thrombocytopenia. Okay.
Yes.
So yeah, that would be all about the valproic acid, nothing much important. Other uses are important, and these are the myoclonic seizures, the bipolar disorders, and the migraine prophylaxis. So for the epilepsy, okay, you can use the carbamazepine, okay, you can use the lamotrigine, and you can use the valproic acid for the uh, for the bipolar disorder. Okay.
Yes.
Okay. So now last you have the Vika pattern, which inhibits the gamma transaminase. Okay, and as a result, it will be inhibiting the metabolism of my GABA. So it will inhibit the postsynaptic neurotransmission. It only can be used for the partial seizures. Okay, it can cause the permanent vision loss, and that is a black box warning. Nothing much about that disorder, this drug. So any doubt on any seizure drug?
No, thank you.
No, thank
So
you.
you must remember all the side effects. These are the important ones. Okay, you must remember what drug can be used where, and for that you can refer back to a table we have draw in the epilepsy part, right? And yeah, you must remember the mechanism of action is important, because nowadays Stephen will ask you this mechanism of action most commonly. Other than the drugs, the another option to prevent this epilepsy is the ketogenic diet. Okay, and that will make your body to burn the fats instead of the carbs. So as a result, your brain will use the keto acids, the ketone bodies, as the source of energy, not the carbohydrates, not the glucose, and that can and it is shown in the researches that it can inhibit the seizures also. Okay, so other treatment other than the these drugs are the ketogenic diet. Okay.
Yeah.
Yes.
Then you have the drugs for the neuropathic pain. Let's discuss them. First, you have the tricyclic antidepressants like the amitriptyline and the nortriptylines. You have the SNRIs like the duloxetine, and they will decrease the reactive of the sodium and the norepinephrine, and as a result, it will inhibit the pain signals. Second, you have the anticonvulsants like the gabapentin and the pregabalin. They will inhibit the calcium channels, and as a result, inhibit the release of all the excitatory neurotransmitters. So inhibiting the depolarization of the neurons. Then you have the opioids. Although opioids, they do not have much efficacy in case of neuropathic pain, and they have many side effects, and that's why you won't use the opioids generally in case of neuropathic pain. But if the severe pain is there, which is not controlled by any of these drugs, in that case, you can use the opioids only. Okay, they will decrease the P substance at the spinal level, and they will decrease the GABA at the CNS. Okay, after activating the opioid receptors. Then you have the casapsin, which is a topical use. So if the patient do not want to use any oral therapy or any IV therapy, you can give the patient casapsin cream, which is a topical therapy, and they will inhibit the and they will cause the loss of membrane potential. They will decrease the membrane potential. Okay, and so it will work on the nociceptive fibers, and these fibers are responsible for the pain in your periphery, the nociceptive fibers. Then you have the lidocaine. You guys already know, topical anesthetic that will inhibit the sodium channels. So it decreases the depolarization of the neurons in the peripheral nerves. Okay. And the TCA, SNRIs, anticonvulsant, these are the first line therapy you will use for the neuropathic pain. Okay. Glutamate and the substance P are the major neurotransmitters that are responsible for the pain. To inhibit that, you either can increase the GABA concentration so that the the pain could be would decreased, or you can inhibit the calcium channels, right? Or it can inhibit the sodium channels to decrease the pain, right? Ultimately, you want to decrease the nerve impulses, right? So please remember TCA, SNRI, anticonvulsants for the first line therapy. Then you can use the casapsin, topical cream, lidocaine, and finally, if none of the drug work, you can use the opioids also. Any doubt?
No, thank you.
No, thank you.
Then you have the barbiturates, okay? And the function of the barbiturates is to increase the duration of the calcium channels. And as a result, the GABA influx will occur. Sorry, the calcium influx will occur, and that will lead to the hyperpolarization of the neurons, and that will decrease the neuronal firings. Okay, uses includes the anxiety, seizures, insomnia, anesthesia, also thiopental, for example. Okay, you won't use these drugs nowadays because of lots of side effects and unsafe drugs they are. Okay, so you mainly use the benzodiazepines for that purpose. Side effects include the respiratory and the serious depression because they are activating the inhibitory neurotransmitters, right? They're inactivating the activating neurotransmitters. So they will cause the respiratory serious depression. Okay, bradypnea can occur, bradycardia will occur. Serious depression, drowsiness can lead to that. Dependence of these drugs can happen. Drug interaction, like they induces the cytochrome P450. Okay, so it can increase or decrease the concentration of other drugs also. Overdose, okay, you need to give only the supportive treatment because there is no any drug now form that can inhibit the barbiturates. So the treatment only include the supportive. Okay, and it will be contraindicated in the porphyria. Does anyone know why?
Increases heme production,
How?
acting on ALA synthase.
How is that happen? Cytochrome P450. ALA synthetase is dependent upon the cytochrome P450 for its activity, right? If you have activation of cytochrome P450, that will activate the ALA synthetase, okay?
Yes.
So that's why you need to, you won't use these drugs in the porphyria.